Okay, it seems like we have almost everyone in, 78 people for this panel session. Again, good morning, everyone. Happy Thursday. It's a beautiful day here in Phoenix. I am Juan David Aristizabal. I work for Molina Complete Care, and we are a proud sponsor of this conference today. I am going to be moderating this amazing panel with some amazing professionals. We're going to have from 9:37 already to 11:15. So each one of you is going to have about 30 minutes, 32 minutes, and that includes the Q&A portion of your presentation. Mario and panelists, I don't know if you want to do Q&A right after each presentation, or if you want to do it at the end of the three presentations. I'm just open to your suggestions.
Yep, that's really up to you guys how you want to handle it.
I was thinking, maybe right after each presentation we have the Q&A, and if somebody has any additional questions at the end, I think we can do it like that. So let's go ahead and let me just give me one sec. I'm gonna do the intro so we don't. Sorry, my computer is acting up a little bit. Okay. So our panel today, we have Janine Fowler. Ms. Fowler currently serves as the Program Operations Administrator for Maricopa County Department of Public Health. Since February 2020, she has primarily served as the Operation Chief for Maricopa County's COVID-19 response, where she was responsible for units working on testing, vaccine, housing, and fatality management. In addition, she served as a member of the county's COVID-19 policy team. In non-COVID times, Ms. Fowler oversees the Office of Community Empowerment, which includes the department's Community Health Assessment and Improvement Plan, as well as its newly funded health disparity work. The Office of Healthcare Innovation, which includes the department's substance abuse work, the Office of Healthy Aging, the Office of Communications and Marketing, and the Office of Performance Improvement. That is a lot. For a full bio, you guys can go to the conference website and the agenda, and you can see the full bio for our presenters. Next is Jean Nisihijimana. I hope I said that correctly. Ms. Nisihijimana is the co-founder and program manager of the Refugee Women's Health Clinic at Valleywise Health Medical Center in Phoenix, where she also chairs the Refugee Women's Health Community Advisory Coalition. Originally from Burundi, her refugee journey and resilience inspire a passionate work that impacts the lives of underserved women globally. Her work involves the design and coordination of culturally grounded health literacy programs, community partner for research activities that are co-designed and co-implemented by an interdisciplinary multicultural staff, volunteers, and community members. In this capacity, she launched a robust and innovative team of culturally health navigators, nationally recognized and a first of its kind in Arizona, to ensure seamless transition for refugees and navigating the healthcare system. Additionally, she developed the trainer curriculum and adapted screening and assessment tools for intimate partner violence and sexual and gender-based violence, advocates to adequately address intimate partner and sexual violence. Sexual violence in minority and refugee population. She facilitated a community partner approach to implement the use of refugee health screener to assess and evaluate refugee women for behavioral health concerns. Last but not least will be Will Humble. Mr. Humble is a longtime public health enthusiast and is currently the executive director for the Arizona Public Health Association. His 30 years in public health include more than 2 decades at the Arizona Department of Health Services, where he served in various roles, including as the director from 2009 to 2015. Prior to being appointed director, he worked at various capacities in the public health preparedness service line. Most recently, he was a health policy director of the University of Arizona from 2015 to 2017. He continues to be involved in health policy in his role with the Arizona Public Health Association and as adjunct faculty with the Arizona, with U of A, Mel and Edith Zuckerman College of Public Health. Again, for full bios, please go to the conference website. So I'm gonna start with Ms. Fowler. You have the floor. Please go ahead and share your PowerPoint. And I'm gonna be managing time, so I will let you know when we have 5 minutes before your time is up. Go ahead, thank you.
Great, thank you so much. Can you see my screen?
Yes, we can see it.
Okay, perfect. Well, thank you for having me today. I really appreciate it. We've been very, very busy in public health for about 16 months or so. And I'm happy to share with you some of the work that we've done addressing health disparity with COVID vaccine distribution. So you'll see in the slide just a few of our fun photos of our year or so in review. Okay, let's see if I can get this moving. Here we go. So for those who aren't as familiar with Maricopa County, just like to level set and share. So Maricopa County is the nation's fastest growing county, and we're home to about 4.5 million people. Important to know that for those 4.5 million people, there's one health department, and that would be us, Maricopa County Public Health. We are the 4th most populous county in the United States. We contain about 62% of Arizona's population, 9,224 square miles, rural, tribal, metro. So you can understand how doing a mass vaccination campaign for a community of our size could bring with it a host of challenges, which I'm going to talk a little bit about. Before I get into that, it wouldn't be a public health presentation without a little data. So I just wanted to share a little of our disparity data. This data can also be found on our website. So that's maricopa.gov/COVID-19. We have a lot of information, obviously, about the response and our COVID-19 data. So you'll see here just a little information about case rates and hospitalizations. Really the takeaway here is to take a look at our American Indian or Alaska Natives and just the rates that we're seeing for cases and hospitalizations. Also important to note, Hispanics or Latinos also are showing a higher case rate and hospitalization rate. I think it's important to note from this slide, I know it's kind of small, and if you look back on our website or these slides later, you'll see that for race data, we only have about 55% of cases reported race data. So we are missing quite a bit of race data, unfortunately. This is a national trend, not just a Maricopa County issue. Also with ethnicity, we have about 53% of our of ethnicity data available to us. Little information about communities of color. This was updated September 9th, but you can see closely, again, looking at American Indian or Alaska Native, not Hispanics, they're 3.5 times more likely to be hospitalized with COVID-19 and 2.5 times more likely to die of COVID-19. Again, we're missing a lot of data, but from the data that we've gathered, this is some national data from CDC. You know, this is a little bit small. Again, all of this can be found on our website, but I wanted to give you a flavor of what kind of data is available should you be interested in learning more. So this is the number and percentage of Maricopa County residents vaccinated, those people that are aged 10 plus with greater than 1 dose of COVID-19 vaccine by race. And this, I'm going to talk a lot about vaccine, but I wanted to, at the top of the presentation, help everyone to understand sort of where we're at as we try to make vaccine accessible to our population. So some noteworthy data points from this slide, again, would be looking at our American Indian or Alaska Natives. We're vaccinating this population at a higher rate, which is great. We're also, it's also important to note that Black or African American, we are seeing a much lower rate of uptake of vaccine, which we're trying hard to rectify. And on that lower graph, you'll see that we're about the same rate or percentage rate when we look at Hispanics versus non-Hispanics. For everybody here today, this is not going to be groundbreaking information, but I think it's important that we talk a little bit about the factors impacting health equity. Health equity obviously being a much bigger issue than just vaccine equity or vaccine access, but obviously vaccine plays a role in that. So things like discrimination leads to chronic and toxic stress, shapes social and economic factors. We're all familiar with social determinants of health. So there's a little graph there to show all of the aspects of social determinants of health that play into this, play into health equity. Also, I think it's important and was very made very clear during the pandemic that occupation plays a major role in access to care, health equity. So those individuals in front-facing jobs who oftentimes lower paying jobs, oftentimes jobs, for example, in it could be front-end restaurant workers, it could be people working in manufacturing, essential settings where there might not be paid time off. All of these aspects played into really making it difficult for these individuals to access vaccine at times that were suitable for them, but B, to be able to take time off if someone in the household was diagnosed with COVID, to be able to properly isolate or quarantine at home. Other issues that we see every day with our healthcare system in terms of health equity, childcare issues, transportation issues, insurance issues. Some additional vaccine barriers that I just wanted to mention were language played a major role, not just Spanish and English, but we have done a lot of work specifically with our refugee communities. We've experienced a lot of languages that we had a really hard time just communicating and ensuring that we had proper processes in place to make sure we could communicate with all members of our community. Tech literacy, we experienced this early on with the vaccine management system, people being able to log on and be able to get a vaccine appointment. Overall literacy, being able to understand what vaccine, when, where, all of the information both public health and CDC was pushing through. Of course, the vaccine hesitancy issues that we've all seen in the media. And then hugely, and cannot be understated, just the amount of misinformation that is out in the community. So just jumping into our vaccine approach, and I have a lot of slides about sort of what we've done to try to make vaccine accessible, but from the get-go, really our overall approach and strategy was just to make vaccine as easily accessible to everybody who wants it. So we know that there's still lots of issues with vaccine hesitancy. We've worked with partners just to try to make sure that there's good information out there. But ways that we tried to make vaccine easily accessible included making vaccine available in convenient locations and at convenient times, provided in a safe, trusted environment, whatever that looked like for the communities that we were serving. Making it as easy to sign up for. So as soon as we were able to allow walk-ins, making that available, working really hard to make sure that knowing the audience that we were serving at vaccine events, so making sure information was culturally relevant, and trying to make vaccine events accessible for people with a variety of functional needs. These were our goals. You know, I would be remiss at saying that we didn't always meet these goals. This is what we aim to do for every event, and we learned early on, and we continue to learn, and we don't always meet all of these bullets, but we sure do our best to try. as public health, we really try to use data as our roadmap for deciding where and when to do events. So we spend a lot of time looking at vaccine uptake, where our vaccine rates are highest, where our vaccine rates are lowest. In those areas where vaccine uptake is low, trying to get to the why, working with community partners in those areas to get to that why, and making vaccine accessible in those areas. So just a little bit about some of the tools that we have used. We've got on our website, which I encourage you to check out, we do have an interactive map. So this helps, obviously, recognizing that not everybody is technologically literate, but we do have this interactive map with vaccine locations around the valley. And early on, it talked about phases and eligibility groups. Today, it really just talks about where vaccine is available. For those not comfortable with computers, we have set up multiple phone lines. I encourage you, if you need more information about COVID or populations that you serve need more information about COVID, we have 506-6767, which is the phones are answered by public health staffers here. We also have a contractual relationship with 211 with Solari, and they are answering questions and have been for a very long time to help people get access to vaccine and answer questions about COVID. We also worked a few months back, probably 4 or 5 months ago, we launched Promotora network through 211. And what that is that we have a network of promotoras who are able to answer questions, obviously in Spanish. Early on, it was really about vaccine related questions, where to access vaccine, how to access vaccine. And now we're expanding that program really to include other social services. So quickly, I'll just go through a brief history of COVID-19 vaccine distribution here in Maricopa County. Started way back in December, that should say 2020, and January 2021. And as you recall, vaccine was very limited up front, and we started with just points of distribution or pods for healthcare workers and first responders. Some of those successes for us were that the hospital systems managed that heavy burden. They were geographically dispersed, and it was a controlled environment, which we had to do just because of the limit on vaccine at the time. The challenges that we experienced at that time was a recently purchased vaccine management system didn't have the proper time for testing prior to rollouts. We had a lot of technical issues. We were using multiple ways of registering. Some of our healthcare partners used their own system. Some used the state VMS system. That created some challenges. And there was just a lot of demand in the community and not a lot of supply. Moving on to February-ish through May, as you recall, Arizona Department of Health Services opened statewide drive-through mass vax points of dispensing in various areas around Maricopa County and around the state. Successes were that many people were able to be vaccinated quickly. There was consistent times, locations, it was free, but some challenges that arose were still some tech literacy problems. Transportation to these sites was a challenge. And we still felt a lot of our underserved groups lacked access to these big statewide drive-through sites. At that same time, Maricopa County Local Public Health was really, our charge was to manage these pop-up vaccine clinics and really dig deep into the community and try to reach all those individuals that couldn't make it to those mass vax sites. So some of the successes that we've seen and have seen and are seeing is that we're able to bring vaccine right to the community. The goal being that transportation hopefully doesn't become a barrier to accessing vaccine. We've taken out the technological issues. So walk-up clinics are almost the only clinics that we offer at this point. And they're always free. Often almost all the time hosted in partnership with a community partner. The challenges for this sort of operation is that it requires a lot of marketing because we're constantly moving around. So we might be in one location for a weekend and then we won't be back to that location for a few months. So it's really important that we reach everybody in that area to let them know when we're going to be there as quickly as possible. It has been challenging to plan for staffing because it's a walk-up scenario. We never know event to event how many people to expect. Two of the bigger issues that we continue to address are ensuring cultural competency at our events. We work with a lot of vendors to help us reach the community. Not every vendor has the same level of cultural competency. And we all feel that we can always get better, and we continue to try to improve at reaching those who have access and functional needs. I'm going to talk just a little bit about our partnerships because I can't say enough that this has been a truly community-wide effort for us to be able to go out and offer as much vaccine as we have in the community. So I want to highlight some of our partnerships. If you're on the phone and I've missed you, I'm really sorry. There's been so many and I've tried to capture as many as I possibly can. So as I've said, this couldn't have been done. Public health is not set up to do this sort of mass vax campaign alone. And there's no way we would have been able to offer as much vaccine as we have in Maricopa County without the work of all of our community partners. This includes cities, community faith-based organizations, healthcare providers, refugee agencies, employers, cultural leaders. The list goes on and on. A little bit about our, I'm going to start with education. We have spent a lot of time supporting our school workforce. Obviously, really important. Our teachers are the front lines. They were one of the early populations to get access to vaccine. We've worked we've offered vaccine to every district in Maricopa County. We've partnered with districts, and each district has chosen to do vaccine in sort of with their own little flavor, which has been fantastic. And we've used, as you can see from the slide, just various methods to be able to reach out first to school staff, and then later on when vaccine became available to 12 plus to those individuals as well. So for school staff pods, we were able to host 59 events, over 54,000 doses were administered. I also wanted to highlight on this slide that Albertsons, Safeway, and Fry's have been just tremendous partners to public health in our vaccine event. They have really worked so collaboratively with us in the schools to make sure that school staff had access to the vaccine. What we're especially proud of is approximately 1/3 of the entire school and child care workforce in Maricopa has been immunized. Similar to schools, we've done a lot of work with childcare. All licensed and unlicensed childcare workers were eligible for vaccine at a school pod, so they could go to any school location that was offering a site. And remember, this was early on when vaccine was limited. So this is at a time where people couldn't just go to a pharmacy, for example. We did robocalls to county child care centers, email notifications, and we worked with Promotora Network to help educate unlicensed child care workers to really help people understand the importance of getting vaccinated. Work closely with higher ed, all of our universities. We've been working very collaboratively to make sure all those students get access to vaccine. Close contact industries. This is some pictures of some events. We've done special event planning for Valley Metro, US Postal Service, funeral workers, restaurant workers, airport workers, farm, ag workers. It's been really great. Our staff has spent a lot of time working with farm and ag workers, going out to on the outskirts of Maricopa County to make sure these workers get access to vaccine who often lack any access to healthcare. We've also worked with other diverse communities. We've spent a lot of time with the Asian American and Pacific Islander associations, Korean Nurses Association. You can all read it on the slide. There's many. Just making sure, again, the theme of all of these events are really going to where people are most comfortable and making a vaccine available where the people are, not making people go to the vaccine. So other underserved or hard to reach groups that we've spent a lot of time working with include older adults, those who are hard of hearing, homeless, transit dependent, low income, African-American communities we've had challenges increasing the rate of vaccine, our refugee population, Hispanic community, Islamic community, other communities with language barriers. And then really trying to be where the people are, really going to those cultural and religious, being with individuals during cultural and religious observances, First Friday events. We've done events with LGBTQ youth, spent a lot of time with IRC and Refugee Rice, Refugee and Community Empowerment. And we're very proud. We've been working extremely hard to make sure we have information available in multiple languages and working with the community to really be culturally competent. I know some of our partners might be here today that we've worked with, our faith-based organizations. We feel like our faith-based organizations are just so well positioned to spread the word about vaccine. And we really feel like it's our role just to provide our faith-based organizations the information they need to pass on to those individuals in their congregations.
Ms. Fowler, sorry to interrupt. You have about 5 minutes and you have a good amount of questions waiting for you. So I just want to make you aware.
Okay.
You.
I will go through real fast. These are more pictures. This was information about just how we've been getting the word out. Nothing here is necessarily groundbreaking. Oops. And I've talked a little bit about that. A little bit about our volunteers that I really just wanted everyone to be aware of. We have had 16,670 new volunteers since April 1st, which has been unheard of. Our volunteers have really filled in the gaps everywhere we've needed them during the response. We can't speak enough about all the different people that have come forth to help us with this response. Another area that I wanted to make sure we covered quickly was congregate settings. So we have done a lot of work just ensuring that people who are in long-term care facilities, homebound, had access to vaccine. Some of the statistics are there that if you're interested, you can read later. Been doing a lot of work with making sure people who are experiencing homelessness have access to housing if they have tested positive for COVID, but in addition, making sure that those individuals have access to vaccine. So this is my last slide, but moving forward, we just completed our COVID impact survey. I encourage you all, we just posted it yesterday. Go to maricopahealthmatters.com to see our regional outbreaks. It's really great information about information we got back from the community, how COVID has impacted them. We're working on some pretty large grants we just received from the federal government that focus on diversity and vaccine equity. We're building a plan for children aged 5 through 12 that should be coming any time now. We're waiting feverishly today for ACIP to finish their meeting to figure out how we're going to move forward with booster shots and preparing for flu season. So that was Vaccine in a Minute. Happy to take some questions, and this is my information. So if anybody wants to reach out, that's my puppy Finn.
Thank you so much for going through all of that so quickly. Again, I'm sorry that we took some time at the beginning with the issues we're having with technical difficulties. So I'm going to go through what I have in the chat box. This one seems to be a comment. It doesn't seem to be a question, but it says non-Hispanic Latino and Hispanic Latino difference in surveys. Seems like it's a comment. Not sure if you have anything regarding that.
I'm sorry, could you, so is the question?
non-Hispanic Latino and Hispanic Latino difference in surveys.
Difference
It-
in,
In surveys, I think that's at the beginning when you shared the first data that you
Yeah.
had. It seems to be a comment, but I mean, I don't know if you have anything in addition to that, to comment differences between Latinos and non-Latinos. I'm not sure about exactly about what it doesn't say in the comment.
yeah, I'm not really sure exactly how to best respond to that. We do obviously are tracking that data. I don't know, maybe Will would have more to add on that. I'm not really sure.
Okay, well, let's move on to the next one. Question says, do you think there will be a decrease in vaccine hesitancy if the vaccine was offered at one's physician's office?
Yes, I do, because I do believe we know from the research and from the data that people are more likely to take any vaccine if it's offered through their primary care physician. The problem that we have is the system. So the CDC requires physicians to go through a special process in order to get COVID vaccine. That's different from every other vaccine. Administratively, it was a lot of work for physicians. And the vaccines came in pretty large. Physicians had to order a large amount of vaccine, and a lot of physicians simply couldn't go through that much vaccine, and they didn't want to waste it. So they were put in a pretty difficult position, which is why you're not seeing, I think, as many physicians as we would like. It's understandable why so many physicians aren't offering COVID vaccine.
Thank you. Next question says, what is your advice or best practices in identifying partners or allies and building relationships with them?
Yeah, I think that we've used a lot of different ways of going about that. Sometimes it's been just cold calling and really talking to people within a certain zip code or a certain community, trying to really understand who is it in that community that helps make that community tick, and working with those individuals. Sometimes it's those warm handoffs. We know somebody who knows somebody. Or maybe it's the city that has a really good relationship. So we work with the city who knows somebody in that community. I think there's no one size fits all. I think it's really doing your research and trying to understand that community that you're trying to reach.
Thank you. Next question says, do any vaccines require any pre-medical screening?
Pre-medical screening. Don't believe so. I don't believe so.
Okay, so I have some other questions and comments. It says, I heard that ADHS prevented the county health departments from implementing their own appointment system that they could control and update more frequently. Is that true?
We collectively, all 15 counties in the state, made a decision last October that we would attempt to use one system. So that's what we tried to do.
Okay, thank you. And our next one says, how did they address transportation issues? I'm not sure what that refers to. I'm not sure if that is for people going to vaccine appointments.
I not really knowing where that question is coming from. All I can say is that we, throughout the response, we have been, like many of our partners, working with like the Ubers and Lyfts and other organizations to try to reduce the barrier of transportation.
Thank you. Next one. What are the plans for rollout once the Pfizer vaccine is authorized for 5 to 11-year-olds?
That's a great question. We're working on that as we speak. We have a lot of great partnerships with the schools, so I imagine the schools will play a role with that. But we're in a much better position than we were at the beginning of the year. Right now, there's no or vaccine is readily available. So I think there'll be a lot of locations where kids will be able to access vaccine.
Okay. I think this is all I had in the chat box. Thank you so much, Ms. Fowler. I think we will wait to see if we have any additional questions at the end. So if you want to
Sure.
just stay with us, that would be great. Thank you so much. I appreciate your time.
Okay, thank you.
Okay, so moving on. Miss Nisi Hijimana, are you ready?
Yes.
Okay, the floor is all yours. So go ahead and start your presentation and I will time you and I'll let you know when you have 5 minutes before the time, okay?
And you will be advancing my slides, right?
No, I think Mario has your presentation and he will be managing that behind the scenes, correct, Mario?
Yep. Just say
Very
next
nice.
slide.
Perfect, thank you.
Thank you very much. Today, I'm here to present on how cultural health navigators at ValueWise Health are playing a great and critical role in responding to COVID-19 in the refugee community.
Cultural health navigators.
I'm having some echo. Can you hear me okay?
Yes,
Yeah.
do you have, are you using your phone and also the audio from the computer? Because maybe that will create some echo, some feedback.
The audio hit on the.
Oh, right now you don't have any feedback right now, so go ahead and continue with the presentation. We'll see what happens.
Thank you very much. So I would like to share some quick facts. At ValueWise Health, around May of 2020, for the first 3 weeks of May, between exactly May 6th through May 26th of 2020, in our labor and delivery department, they tested over 105 patients using PCR. At that time, it was revealed that 17% among refugees tested positive, whereas only 8% among general population tested positive. With that said, we are able to confirm the disparities that Janet Flower just demonstrated in her slides. Next slide, please. We were very fortunate that the Department of Economic Security, through our state refugee office, was able to fund ValueWise Health, so cultural health navigators could intervene in order to help in responding to COVID-19 within the refugee communities, in making sure that they communicate with patients who were at increased high risk for COVID-19. They were educating those patients about COVID-19. They were also providing resources and referring patients out as necessary while performing contact tracing and case investigation as well. Next slide. For those who are not aware of who cultural health navigators are, these are refugees themselves who are trusted members of their own communities. They are bicultural interpreters. They share the same cultural beliefs, the same social norms and values. They are there to remove structural barriers to care, such as transportation, and making sure that they provide all care coordination related activities to promote a continuum of care. They do a lot while helping refugees and other immigrants navigating the healthcare system. And as a matter of fact, we call them cultural health brokers for healthy quality outcomes. During their roles and activities, they were charged to make sure that client barriers are removed in accessing care so they can retain meaningful access to care while they are seeking healthcare at ValueWise Health. They were assisting patients with COVID-19 testing, with contact tracing. They were ensuring patients are able to follow quarantine and isolation techniques, as well as educating them on other important information they needed to stay safe and healthy. At the same time, they had to make sure that all referrals to mainstream and refugee-specific benefits and services were provided. Every cultural health navigator had a care plan for their enrolled individuals. With that said, we were charged with certain goals, such as to ensure that 100% of all directed support clients were obtaining those services listed above, while also they maintain their health coverage at all times. I want to let you know that refugees and the immigrants in the communities were also receiving health literacy and educational materials in the languages they speak. ValueWise Health Cultural Health Navigators have contributed in creating scripts for health videos and also participating in the creation of those health videos. Those health videos have been disseminated in over 11 different languages, and we have received a lot of views. And then our patients also, they do like to view them before they even come to appointment, so they are prepared to ask questions to their providers. Next slide, please. There were some outreach strategies employed while we were assessing the needs of our various patients. I just want to share that for those who didn't know yet, nearly 750,000 refugees have been resettled in the United States from 2008 to 2019. And we're having more, and even more now with the crisis of the Afghani evacuees. Why refugees are at increased risk? Their living arrangements are in such a way it's very hard and difficult to follow the quarantine and isolation techniques. Working conditions are very poor. They have underlying medical conditions due to the trauma and suffering they suffered prior to resettlement in the United States. They also have a disconnect, they are facing a disconnect here in the host country between themselves and the medical providers, which makes it difficult to access healthcare in general. So while cultural navigators are out doing outreach, they are making sure that patients don't have any communication issues. They want to ensure the patients are able to stay in contact with their cultural navigators, that they have their phone numbers, and that they also have someone they would trust in case they need to reach a provider. They are also asking patients whether they have another method of communication that they prefer. Is it through WhatsApp chat? Is it through other social media and so forth? They have to ensure that if a message must be sent to them, it's gonna get to them because the patient will have communicated it their best way to receive messages. Patient understanding of COVID-19 stigma and discrimination. Some patients might think COVID-19 is a taboo, especially when they are told they have to quarantine, they should not go out. Given that this becomes an issue to them accessing social support that they strongly believe in and that they strongly rely on. So this then can be a problem to whether or not they are able to access care. Barriers to following COVID-19 recommendations, we need to know, is this a trust issue? Do they trust the person bringing them messages? Do they have the right provider to address this? And so forth and so forth. Barriers to accessing healthcare and social support. I already mentioned this. At this moment, our cultural health navigators stood up and they were held up to their standards in their communities because in the community they are trusted, they are seen as leaders. So if they were to disconnect at some point, then they would have failed to their role as a leader. They would have failed to their role as people who are teaching them, who are mentoring them, and they would have failed themselves to be in the position of power that the community put them in. With that, they were making sure that they do some weekly check-ins, some weekly home visits in considerations of all the precautions, safety protocols, and social distancing, but they were constantly in touch with all their patients. Next slide. These are preliminary outcomes of how wonderful the work they did has been impactful. From a medical and health education standpoint, I want to give you just some outcome of what has been provided between April and June 2021. We provided outreach in various refugee communities and complex apartments and reached out to 165 refugees who received health education around COVID-19 and vaccines and COVID testing. 140 were helped in enrolling for vaccines, and out of those, 115 successfully completed full vaccination, which is 82%. So we consider that it was success, even though Janet Flowers told us that disparity in rate of vaccine is low. Yes, it's low, but if the strategy is well targeted and then well ordered, we can do better. We can do better if we employ the right people to target the right population. Direct services were offered to a total of 125 COVID-related patients, of whom 27 were confirmed cases, and 98% were non-COVID. Some of the goals we already shared them before. They had to show whether isolation techniques were completed and followed. COVID test was completed with partial or full vaccination. We were trying to follow patients to make sure they were cleared for routine care in case they needed to go back home. No, I'm sorry, in case they were supposed to go back to work. We were also making sure that necessary follow-up with providers were done. Services overall were mainly in person. Many refugees, they were struggling with phone, virtual meetings and visit with their providers, and they were really insisting that they be seen in person as needed. And the cultural health navigators, they were screening them properly prior to coming to the visit, which allowed them to complete those in-person visits. In terms of health screening, we were able to screen for behavioral health using RHS-15, Refugee Health Screener. And that was from the year 2020 to July 31st, 2021. As you can see, we had 21 positive screener in 2020, whereas in 2021, only in 7 months, we had already 41 in 7 months, compared to a year of 2020 when we had 21. There was an increase of almost 22, percent. There was of positive screeners. It was a 41% increase in terms of positive screeners. This could relate to the aftermath of COVID-19 that the refugee patients are experiencing. We can see that the 2020 was still, everybody was still under shock, learning what is happening. Now they have learned the realities. They are suffering the realities of it. They are being impacted. Some of them are losing their jobs. Social support has diminished, whereas they were relying on one another. So the trauma of this COVID has been an impact on their well-being, and that's why we are observing an increase just in 2021 of how they feel about the whole situation. Next slide. And I think that was the last slide. Thank you very much. I end there, but I just want to share that based on what Janet Flower just shared, if there is a grant or there is a funding opportunity to address diversity and equity, let's really look at where those disparities are, really are. We are already dealing with minorities. Refugees are minorities in many aspects, in many aspects, and those disparities are even deeper among refugees and other immigrants. With language being barriers, with with health literacy being a huge barrier, with accessibility being a huge barrier, we need to rethink the strategy so we can use the asset that we have in our own communities to help serve our various constituents. It should be very important that at the public health level, while we are addressing COVID-19, we think of whether or not our population is accessing care. At what level are they accessing care? And who truly be involved in accessing care. I will end there, and then I'm open to questions should you have some. Thank you.
Thank you so much. You actually ended way ahead of time. So we are kind of like going back to some of the time we lost at the beginning. We have a few questions in the chat, but I think this could be answered by anyone on the panel that would like to take the question. There's one question that I don't know if we actually have the data. Maybe the ADHS website will have the data. The question is, what demographic had the excess positivity from May 6 to May 27? I think that is, a very specific question, and that data probably, Mr. Humble, probably, do you know if the ADHS website has the data broken out like that?
I can answer what we at Labor and Delivery found in terms of the broken refugee groups. So this, out of the 17%, 21% were refugees from Central Africa, which is now dominated by the Democratic Republic of Congo. So the Congolese shown that they had high rate in positivity.
Okay.
But I would say I think that Janet Flower might have the disaggregated data per ethnicity among refugees, certainly.
Thank you. And this, the question is about May 6 to May 26, which is, some time ago. I'm not sure why that question is so specific to data related to those 2 weeks in May. So again, maybe somebody can direct this person to where they can get it.
I think that you're right. I think that the ADHS website would probably be the best resource for that. And David, I just one quick question or comment. This is Janine again. I really appreciated Jean's presentation, and I just wanted to add, I know I had a lot to say in my presentation, but we are, as part of our new health disparity grant money we received from CDC, we are building a new team that we're very excited about. We actually just made an offer to a refugee immigrant migrant supervisor, and we're building a clinical navigator program at Maricopa County Public Health. We have never had such a program, so we're all very excited to get this program launched. So I really appreciated your comments.
Very great.
Thank you. No, that's a great comment. I appreciate that. Again, we have some additional time because, Sean's presentation was a little bit shorter. Mr. Humble, do you have any other comments about this data broken out by positivity and demographics anywhere?
Just only to remind folks that as they're looking for data, there's there's really 3 places to visit. Number one, if you're in Maricopa County, I would start at the Maricopa County Department of Public Health website. That will give you more in-depth information than the State Health Department's website will. Obviously, the State Health Department has many tabs with some interesting information that's relevant. But also remember to go to the ASU Biodesign Institute's COVID Trends website if you're looking for longer term sort of trend-like data for either positivity, new cases per 100,000, 7-day moving averages, and so forth. So those are the 3 sources of information that I usually go to. And then, of course, a terrific resource is the weekly reports that Dr. Joe Gerald puts out from the U of A. He does about a 7-page weekly statistical review, all the epi curves, dives into detail with hospital capacity and availability. And so I put those up on my blog every week when they come out, and I think they may even go up somewhere. U of A is such a big organization. I don't know where it would go on U of A, but you can go to azpha.org and look every week at Dr. Gerald's reports.
Thank you so much. I have another question on the chat that says, why the WHO team, the World Health Organization team, has not approved a vaccine that is globally accepted? And that question can be answered by anyone on the panel.
Will, did you want to take that?
Yeah, I can tackle it. Can you repeat the question?
Yes, sir. Why the WHO team has not approved a vaccine that is globally accepted?
Are you talking about the World Health Organization?
Yes, sir. Correct.
Oh, I don't know how they make decisions. So I better not answer that question.
Okay, fair enough. Anybody else on the panel?
I agree with Will.
Thank you. Next question. Jean, maybe this is for you. Do refugees bring a risk of unknown pathogens, and how are they checked?
Can you repeat for me?
Do refugees bring risk of unknown pathogens? How are they checked for those pathogens that refugees, when they're coming into the country, how do the government or how do the country check for those, viruses or pathogens or anything that people may be bringing into the country as refugees?
First of all, I would like to say that before refugees come to the country, they are deeply vetted and they are screened for various medical conditions. And they do have what they call, when they arrive to the country, they will come with the records and they will undergo what they call domestic examination. And it is normally done by the Maricopa County Public Health. The Maricopa County Public Health has a refugee screening department that has to do all screenings and immunization to make sure that infectious disease and other communicable disease are taken care of. And they are treated as well for all, they are also examined for STIs, STDs, and then they have to receive treatment accordingly. They also receive medications for parasites and they are tested as well for that. I will have Janine Flower to speak to that if she has additional information, but as well as I know, a series of immunizations are provided, such as MMR, polio, TB tests, and COVID-19 vaccines. In addition to what they have received prior to coming, because if something were to be diagnosed prior to their arrival, they have to be also under treatment.
Thank you.
Jean, you just hit it on the head. I have nothing to add. Perfect.
Thank you. I have a question that I think you guys are going to love answering. And again, for anyone on the panel, the question says, I do not find scientific data that suggests that lockdowns and wearing face masks and prevent spread of COVID-19. Why has the World Health Organization issued guidelines to national government across the regions of the globe to follow protocols on lockdowns and wearing masks? The international research community need to advise the WHO team in this matter. Again, this person is saying that there's not scientific data that suggests that lockdowns or wearing masks will prevent the spread of COVID-19. So if anyone wants to answer that, I know you guys will be happy to.
I'll cover that in my next presentation about schools.
Perfect. Thank you. Janine, anything?
I think that we could probably, if you don't mind holding that question to make sure, see if Will answers it adequately, and we could always go back to it.
Perfect. Thank you so much. I'll wait for the end. Another question I have says, how how do you overcome fear of social isolation that being quarantined might cause? Anyone on the panel? Overcome fear of social isolation because of being quarantined.
I can start. I think everybody probably has something to say about this. It's obviously a huge issue that we're dealing with. There was a lot of social isolation throughout COVID, and we're all starting to see sort of the implications of that. I think in the public health community, we're all looking towards and have been, there's been, even prior to COVID, we know there's lots of socialization, especially with our older adults. So looking at ways we can engage or help our older adults be more engaged in the community, looking at different best practices for getting people more engaged with the community. But obviously there's no magic bullet here. This is really going to take a community-wide effort. We're all, I think to some extent, we're all retraining ourselves on how to be social again. To some extent, we've all been socially isolated during COVID. And I think together we have to sort of work our way out of it.
Thank you. And I just got a reminder that the next panel is actually on social isolation. So this question will be better answered during that panel session. So, but thank you, Janine, for that. Mr. Humble, I think it's your time. You have the floor. Go ahead and start your presentation. Thank you.
Okay, thanks. So I don't have any PowerPoint, so you can do whatever you want to on the screen for me, or just put my face on there. It's totally up to you. Here's what I'm going to talk about is the evidence-based strategies that schools can use to maximize the opportunity for kids to have in-person instruction this fall, and as well as minimize infection rates among kids and prevent, to the extent possible, downstream cascades in type infections that can occur inside households if kids bring COVID-19 home with them from school and infect the rest of the family and either cause breakthrough cases or actual COVID symptoms among unvaccinated family members. So there's basically 3 evidence-based strategies that schools can use to slow the spread of COVID in classrooms and maximize the opportunity for in-person instruction. And I'll go through each one of those. And then at the end, I'll get into a little bit of a sort of a legal discussion about some of the legal cases that are in front of the courts here in the next. We should be getting decisions shortly. So the first one I'll mention as an evidence-based strategy to keep kids in-person instruction is vaccination. Sadly, that only applies so far to kids from 12 to 18 years old. And so we're talking about some middle schoolers and all the high schoolers at least have the opportunity to get vaccinated if their parents will allow that. I mean, requires, unless the kid is a senior and 18, it requires, the parents to provide the consent for the vaccination. And that, among at least the middle schoolers and the high schools, I would say, is the #1 strategy for families to maximize the chances of their kids having in-person instruction this fall, because as soon as they get their kids vaccinated, they're very unlikely to ever contract COVID-19. If they are exposed to a case in school and they're vaccinated, they're far less likely to be considered a close contact and have to go out on quarantine. And so it's a pretty simple strategy. It's the Pfizer vaccine that's been authorized for those kids. And so my take-home message has been, when I do media events and so forth, is if your kid is 12 and up, the #1 thing for you to do is get your child vaccinated, and that will pretty much ensure that they'll be able to stay in in-person instruction, because even if they're exposed to a student who is unvaccinated, who is infected with COVID, they're very unlikely to and even they are breakthrough cases, they do exist, but extremely rare and highly unlikely to happen. So that's the #1 strategy. Happily, the Pfizer company has turned in, or they haven't turned it in yet, but did a press release at least, that said that their clinical trial data for kids from 5 to 11 years old is complete, and they're getting ready to submit that data to FDA to get the emergency use authorization for their vaccine for kids 11 down to 5 years old. The clinical trial was a little bit different from the previous clinical trials in two respects. Number one is that they used a lower dose because of the lower body weight for those ages. Rather than the 30 microgram doses in the regular Pfizer vaccine, they used 10 microgram doses. And that was one difference from the clinical trial. The second difference is that rather than use the placebo and the vaccine group and send them out into the world and figure out who gets COVID and who doesn't, rather, they gave the vaccine to the placebo and the vaccine group and then measured antibody titers for those kids. Because the vaccine has already been shown to be effective in the older kids, they used that data to allow them really to use a serological test on the 5 to 11-year-olds for the efficacy side of the equation. The safety side of the equation, they did the clinical trial the same as any other clinical trial. And at least the company says that this is not peer-reviewed data or anything yet, that their vaccine was effective and very well tolerated, just as it was in the older kids, and that the 10 microgram dose was adequate to provide very good protection after the 2-dose series. So the company says they'll be turning that into FDA. If the FDA moves, if they do that, and if the FDA moves swiftly through their the vaccine advisory committee within the FDA, and then FDA issues that emergency use authorization, I think the CDC's advisory committee for immunization practices could be hearing that recommendation, that could be hearing the evidence for and making a recommendation for the kids from 5 to 11 by mid-October, which means, and the vaccine is being prepared, and it is, of course, just a 10 microgram dose. And I'm not sure if there'll be different vials or if the practitioners would be expected to draw up just 10 micrograms instead of the regular full dose. I wonder, maybe one of the other panelists, maybe Janine knows the answer to that question, but could be the vaccines available for kids 5 to 11, those elementary school kids, by Halloween. And so I'm tying that into the vaccine strategy for keeping schools open. That will give us another opportunity to keep kids, elementary school kids, in in-person instruction. Now, obviously, if they get the vaccine at the end of October, they're not going to be fully vaccinated until, say, mid-November, but at least they'll have some protection within the first couple of weeks after that first vaccine that will help maximize the chances of in-person instruction for that kid and minimize the chance that they'll get sick with COVID-19. So that's strategy number one, vaccines. Strategy number two is universal indoor masking in classrooms. And I'll talk about cafeterias in a bit, but at least in classrooms, you can, it is well established through the literature that universal masking works. There is a solid evidence base. I know there's additional research, observational studies that are happening in several states, maybe even in Arizona, that are going to shortly shed some additional light on the effectiveness of universal masking. But the best source of information I'll put into the chat right now was published in the British Medical Journal a couple of weeks ago, and they established that universal masking in the classroom cuts COVID-19 transmission by 800%. So think about that, an eightfold decrease in spread of the virus with universal masking. Now, that's with universal masking. It doesn't work if just some kids are wearing a mask and some aren't. I can remember Director Chris saying over and over again, well, everything's okay because I'm going to send my kids to school with a mask. That's not how it works. The mask that you wear protects other people. It prevents the particles from coming out far better than it acts as a filter for kids breathing in. And so what we really need, and for this intervention to be successful and effective, you've got to have universal masking in the classroom with good adherence. And if you're able to do that, you can cut transmission 800%. That's pretty darn good. If you ask me, that intervention in and of itself really makes a huge difference. The BMJR article also showed, interestingly, that filtration also is an effective intervention within the classroom. And by that, I mean the HEPA type filters, the filters that take the indoor air from the classroom, run it through a HEPA filter, which screens out the very fine particles and stops them from being in the air, and sends the clean air out through the HEPA filter. So 2 full-time running HEPA filters that are in good repair and operating properly. If you have 2 of them in the classroom, and you can cut transmission by 400%. So a 4-fold decrease in transmission of the virus just with filtration. So the same study found that if you combine universal masking and full-time HEPA filter filtration, you get upwards of 1,000% or more than a 10 times reduction in transmission in the classroom. So tremendous with that combination. The study also found that an effective strategy is actually the old-fashioned technology, which is ventilation. And the same study found that ventilation can be a very effective tool, depending on how many windows you have open, how much air movement you can create. The problem with Arizona schools is that the vast majority of them were built in an era when energy efficiency was the top priority rather than student aesthetic. I don't know what the right word is, but the elementary school that I went to back in the day had a whole bank of windows that teachers would open all the time when we had good weather. But that is, and all those schools that had that kind of ventilation and windows have, for the most part, been remodeled, and they either eliminated the windows or made them so that you can't open them anymore. And so ventilation is less of an option for Arizona. Many other parts of the country can actually use ventilation effectively if they have better weather and if their schools are built with actually, having windows in them. So, so now we've covered 4 strategies that can help slow spread of the virus within classrooms. Number 1, vaccination. We can do that with 12 and up. We can't do that for 11 and under yet, but that day is coming. And again, probably the most effective the most effective long-term solution to keeping in-person instruction and keeping kids safe is getting kids vaccinated. We covered the importance of universal masking and how masking is only effective if everybody is wearing a mask in the classroom. It is not effective. With the state health department director kept saying, well, if a few are wearing masks, then that kid is protective. No, that is not how it works. You've got to have the entire classroom protected because the masks do a much better job stopping particles from coming out than they do from filtering particles that are coming in. We talked about filtration being an option. And I know there are parents, I see it on Twitter all the time, where parents are coming to their kids' classrooms with HEPA filters under their arms and setting them up in the classrooms. And they're about $120 each. I don't know what the supply chain is like these days because a lot of people are buying HEPA filters because of the classrooms. But I know that parents are donating HEPAs and bring them into their kids' classes. And they're not that noisy either. We have one in my house, and even on high, if the filter's clean, it doesn't make a lot of noise. At least not all. I mean, there's some models maybe that are noisy. I don't know, but super effective tool. We talked about ventilation, a good option if the school has a way of ventilating. But yeah, ventilation. If you have 2 windows open all day long, the study showed you can reduce transmission about 300%. So along the lines basically of filtration as an intervention strategy. The next one I want to talk about is in-school testing so that schools are able to identify cases early or early on in the course before there's a large number of cascading cases that come into the classroom. In Arizona, we're fortunate, not in Arizona, the United States is fortunate in that the the federal funds are available in Arizona. Arizona has $129 million from the federal government to implement mitigation strategies in schools. One of those strategies is testing within the classroom or testing within schools. There's two options in Arizona. Well, really everywhere. If schools, and I know many schools have chosen to go with the rapid antigen test. I think most of them are using, the Abbott's product, the Binax Now home test. And that's the antigen test. It provides results within about 15 minutes. Schools are able to order those from their county health departments, or at least in Maricopa County, they can. I don't know what the supply is like these days, how many tests that schools can order. Maybe Janine could talk about that if we have time at the end. But the Binax Now kits are available. I have a link in my blog that goes to the website that you can go to request those Binax Now kits from Maricopa County Public Health. If you're a school district, they're taking orders from districts, not individual schools. But super effective tool to identify new cases and rapidly. That's the nice thing about the rapid test, is that the school nurse or the administrator has the ability to know very quickly whether the kid is positive. Also, I know some schools are getting those Binax Now kits and sending them home with symptomatic kids, so that the parents can actually do that nasal swab test at home and find out whether the kid is positive within the home. And then they can go from there. And that's an option that avoids the consent that you need to get if you're a school to test a kid. And that sounds kind of simple. Why would you need consent to test a kid just with the nasal swab? But you do. It's the law. So in order to avoid that kind of administrative issue, schools can send the Binax Now home kits back with the kid, and then the parents can call in with the results as soon as they know what those are that afternoon or the next morning. The other option for schools in classroom testing are the actual PCR, the more sensitive polymerase chain reaction. Everyone knows what PCR is these days now. Used to be no one knew what that meant, but everyone does now. So the PCR tests are available as a pooled test. And so those are being administered and run by the state health department. Well, they're not being run, but the state health department contracted with, I think, forgot the company name. So I'm not going to say what the name is because it's probably wrong since I don't know it, but they have a contractor who handles the pooled testing. And the way that works is there are kids whose parents would sign them up for the pooled testing program. And then kids would routinely, on a sort of a measured at some pace, maybe once a week or something, get a pooled test. So there might be, let's say, 25 kids that get a sample collectively put together. And that sample is sent to the laboratory by the contractor. And I think they all go to SnorQuest. And the next morning, the results are known on that PCR test. And so let's say you have a classroom, you test 25 kids, it's all negative, then you know that all the kids are negative. But if you test 25 kids and it comes up positive, obviously it's not 25 kids are positive. It could be one, and probably is, one kid whose sample caused the whole pool to be positive. And then what happens is the school has the contractor brings in the rapid tests. I think it's Binax Now, but I'm not 100% sure. But the rapid test is then available that next morning, so that the pool of kids that tested positive are all given the rapid antigen test, so that they can identify which child is positive. And then that brings me to my next evidence-based strategy that schools can use, which is contact tracing and quarantine of positive kids. So obviously you can't do contact tracing and quarantine unless you're doing testing. So these two kind of go hand in hand. Is school-based testing and contact tracing go hand in hand, because that allows you to quickly identify the positive kid, get them out of the classroom and into home so that they can do home-based type of workbooks and things like that, or maybe some are doing virtual school, although I think they're mostly sending them home with workbooks and things like that these days. But so that's one approach. The other is if kids test positive and the parents call into the school, like the kids are testing positive, just on where parents are testing kids on their own, they tell the school about it. And then schools can find out that kids are positive that way. And then they can still do the contact tracing, identify which of the kids are close contacts. And I won't go into what the definition of close contacts is, because I think Janine would be a better person for that. But it has to do with vaccination status, mask wearing, time, and distance. And you put those pieces together, you can determine what a close contact is. So that's vaccine status, spacing, masking, time. Those are the criteria that you would look for to identify what a close contact is. And then, of course, do quarantine of those kids that were positive contacts, especially if they were unvaccinated. So that brings us to like the list of strategies that help schools keep kids safe and maximize in-person instruction. I'll just tick them off real quick, and then I'll do sort of a legal review after that. Vaccinating kids. Right now, we can vaccinate from 12 to 18. Shortly, at least I hope before Halloween, we can start getting kids from 5 to 11. Universal masking indoors. That cuts transmission 800%. Filtration with 2 HEPA filters running full time can cut transmission in the classroom 400%. Ventilation is an option if it's available at the school, opening windows and so forth. You can adjust the HVAC system to get cleaner air in, but it causes the electrical bill to go up because you're bringing in 105-degree air, at least right now, but it's going to get better. Usually, I've lived here my whole life. Usually like October 7th is the date that I can say, it's finally over. Anyway, pooled or antigen testing at the school, and then contact tracing of those students that are close contacts of positive cases, and of course, sending home the positive cases on hopefully isolation, but more likely quarantine at their home. And so those are the strategies. Now, let me touch on how schools can use those strategies. Some of these strategies schools will always be able to use because they haven't been prohibited, but the most effective strategy, remember, besides vaccination, was universal masking. 800% reduction in transmission in the classroom, and it doesn't cost anything. Masks are practically free. Now, yes, the kids have to wear them, and so there's like a behavioral cost, but in terms of the cost of the actual mask, it's pretty much nothing. And yet, the governor found it in his wisdom to sign a bill that the legislature passed that will prohibit schools from using that #1 most effective high return on investment strategy, universal masking in classrooms, starting, I think, next Thursday. So on September 29th, which is 90 days after the end of the legislative session, schools will be prohibited from using the universal masking strategy directly because of a decision that Governor Ducey made, knowing that the evidence was clear that universal masking helped. He made the decision to sign that bill anyway. And if that goes into effect on the 29th, then I can assure you, we will have a large number of cascading cases among those school districts that had been masking, but will be prohibited from masking because of Governor Ducey's decision to sign that bill. This is on him. This is his responsibility. When you're a governor, it's your job to take ownership of the decisions that you make. He made a decision to sign that bill. He cannot send that off to the legislature and say it's their fault. He signed the bill. It's his responsibility. Now, fortunately, we have some courageous school districts, Phoenix Union being one, that have sued, challenging that, it's called a budget reconciliation bill, charging that the bill is unconstitutional that the governor signed. That's one lawsuit with Phoenix Union. There's another lawsuit with the Arizona School Boards Association, along with the Children's Action Alliance, suing along the same line. So there's really 2 lawsuits tackling the same issue. And it goes like this, that the Arizona State Constitution has a provision in it that says every bill that the legislature passes and the governors sign needs to be of a single subject. So every bill has to be of a single subject, and that single subject needs to be easily identified in the title of the bill. And so what happened this legislative session, as it happens every time, basically, is that legislators who were unable to get bills through their regular committees and so forth and get to the House or Senate floor are in the budget negotiations, they find a way to shoehorn it into the budget. And that's exactly what the anti-mask people did with the collaboration of Governor Ducey to the budget bill. And that is where they slipped in the provision that says in the K-12 funding bill, it's the funding bill for K-12, that schools cannot implement universal masking in the classroom. So that was in the bill that he signed, that he has to take responsibility for. And fortunately, that is being challenged in the courts. Judge O'Connor has heard that bill, or excuse me, that case. And I expect to hear a ruling that was in Maricopa County Superior Court. I expect to hear a decision from the judge at least on whether to issue a temporary restraining order or a preliminary injunction within the next few days. It could even be Friday. If not, it'll be Monday or Tuesday, probably. I doubt that the judge is going to rule on the full case because it has implications for whether there'd have to be a special session to send the whole legislature back to redo the budget. But I do believe that based on an analysis of the likelihood of succeeding on the merits, that I believe the judge is going to issue either a preliminary injunction or a temporary restraining order that will keep the status quo, allowing schools to use universal masking past the 29th. That's what I think will happen. Whatever the judge decides, I'm certain that it will be swiftly elevated to the Arizona Supreme Court because this is a very large, not just public health matter, but a matter of constitutional law. And that is exactly why we have a state Supreme Court. So I see you put your picture back on the screen, which means I'm probably running out of time.
Sorry for interrupting. Yes, you are almost at your time. So I don't know how much more you have. We have a couple questions in the chat box.
No, I'm good. I'm good.
Thank you. You are perfect timing. Thank you so much. I appreciate that. So I think the question we have pending, I believe has been answered. I don't know, Janine or Sean, if you have any other comments for this person that says that there's no scientific data that suggests that lockdowns or wearing masks will actually prevent the spread of COVID-19. I think, Will, you explained that some of those things for school system, not for the general population.
Yeah, I don't think anybody's advocating for another shutdown of bars, restaurants, nightclubs, or anything like that. But the evidence is clear that masking works. The caveat is that it works when it's universal. That's when I'm talking about like cloth masks, surgical masks, the paper masks. Those work when they're universal. The only mask that truly works when it's not universal is a fitted N95 mask. Fitted, not just one from like Home Depot, not fitted. You have to have it fitted. So if you have a fitted N95, then that is effective at protecting you. But the regular masks are effective if they're universal. And that is the issue. And that is what Governor Ducey has prohibited unless the courts send him back to the woodshed.
Thank you. And just, to go along those lines, my daughter is going back to school. She's in 8th grade. Her school, pretty much no one is wearing masks. And this week, her classroom size went from 30 kids to 8. They all left this week feeling sick. One already tested positive. She said that most of the kids that are sick are not vaccinated. And so far, we haven't gotten any communication from the school on any of these issues. So I don't think you have to wait until the 29th. If the mandate goes into effect to see the effects of kids not wearing masks in the school or not being vaccinated.
Right, and I know there are some observational studies, and I'm told that at least in the near future, there's going to be some observational studies that document the effectiveness of masks in schools shortly.
We have a question on the chat that says, how can the clinical trials be turned in when the case control studies are not estimated to be completed until July 30th, 2023?
Well, I can tell you that for the Pfizer the way it all works is the vaccine manufacturer is the one that initiates the process that gets emergency use authorization or approval. The Pfizer company has said in a press release, now this is just a press release, that they've completed their clinical trial as required by the FDA, and that they'll be submitting that data to the FDA, not for approval, but for emergency use authorization in kids from 5 to 11. And then if the FDA authorizes and gives a EUA, then it would go to the CDC for a recommendation. That would usually happen really fast. So the process is much faster than that for the Pfizer vaccine. So the commenter might be talking about a different vaccine, but for the Pfizer vaccine, and Moderna is behind them a little bit. I'm not aware of any trials in kids with Johnson & Johnson.
Thank you. Next question says, how can we convince parents to get their children vaccinated when they personally know of a child who had severe neurological side effects from the vaccine?
Janine, do you want to tackle that? Because I know that's your boots on the ground for that kind of stuff.
You can start, Will, and I can add to what you say.
I'll just start saying it's not a one size fits all strategy. The number one most effective tool, and I think Janine would agree with this and the data supports it, is the personal relationship that the parent has with the pediatrician or primary care provider for the kid. So that is always the place to start for questions like you just asked, is that trusted relationship. I mean, when kids are born, they start going to they go to the pediatrician starting when they're like 1 month old, less than that. I think you go in 2 weeks or something, maybe even the first week. Like, kids are in the pediatric offices all the time, and they are building relationships with the pediatricians, with the nurse practitioners, with even the nursing assistants in that practice. And that's always the best place to start for the question that you just asked. And Janine would probably just going to say the same thing.
Yeah, and the only thing I would add, and what I communicate to people, is that there's no such thing as zero risk in anything. So even if you look at seatbelts, which we know protect, thousands and thousands of lives, we still have individuals who say, yeah, but I could get in a crash with my seatbelt on and not be able to get it off in time, and that could have a negative impact on saving my life. There's not going to be a 0% risk in anything. So I think we've got a higher, the data shows that the chances of when getting vaccinated, obviously there's not zero risk, but there's a much higher chance of getting COVID and having adverse effects of COVID versus the vaccine. So it is a personal decision, but to Will's point, that is a conversation that is to be had between an individual and their doctor.
Thank you for that answer. Next comment and question says, the V-Safe smartphone app from the CDC is my worries. Is this information shared with all? V-Safe smartphone app from the CDC. I don't know if you guys know it.
Yeah, I mean, V-Safe is one of the surveillance systems that tries to identify adverse events. For every vaccine, there's the normal system, which is called the VAERS system, which identifies adverse events as a result of vaccination. But for COVID-19, there's a much deeper surveillance system. V-Safe is one of those. The VA, Veterans Administration, has a separate system that they use. The Indian Health Service has a separate system. Well, not separate, but complementary system. And so I'm not an expert in V-Safe, and Janine, I don't know if you are, but there is a tremendous amount of surveillance on this. Now, the question from the person was about confidentiality. And one of the things about the VAERS and the VSAE system, or any system that's managed by CDC, is that data protection is a #1 and top priority. And so they do everything possible to maintain confidentiality of that information. That's what I could say about that.
I have nothing to add.
Thank you. Last question I have on the chat box says, is there a weight range for the children's vaccine?
Well, what the clinical trial used ages. So it's a 10 microgram dose. And so that you're coming up on this interface where like the 11-year-olds would be getting a 10 microgram dose, but the 12-year-olds are getting a 30 microgram dose. And so that's going to be sort of an odd thing that will be happening once the vaccine for the younger kids is authorized. But the clinical trial looked at all the kids from 5 to 11, and I didn't see anything in the press release from Pfizer suggesting that they looked at body weight. But look for the clinical trial to be published in a peer-reviewed journal, which that needs to happen. That will happen before the vaccine gets authorized, and that publication, whether it's in JAMA or New England Journal of Medicine or Lancet or BMJ or whatever, that data would establish the answer to the question the person asked. But so far, all we have is a press release from Pfizer, and it doesn't talk about weight.
Thank you. One question just came in and says, I'm not sure if I missed it, but is it possible to share the link to the British study
Yeah.
that was recently published? Thank you.
That's a link to my blog, and in the blog, it goes to BMJ.
Thank you so much. And I think that is all the questions we have. We are almost on time. It's 11:18. We were supposed to end at 11:15. So great job, everyone. Thank you so much. And thank you for the questions from all the people attending this session. We had up to 95 people attending this panel session. So thank you so much. I think we are, I'm not sure, but I think we're breaking for lunch and coming back later. I may be wrong. But I want to say thank you to Janine, Jean, and Will for the time, for the presentations, for the information, and for all your expertise and sharing that with all of us today. So if we don't have any more questions, I think we're breaking. Mario, are we taking a break? I'm sorry, I haven't looked at the agenda after this panel session. I'm sorry.
Hey, Juan, yeah, we're ending this session and the next one begins at 11:30, teledentistry. Perfect.
Guys, thank you so much for everything. It's a pleasure to see you, pleasure to have you, and I'll see you in the next session in about 11 minutes. Have a great day. Thank you. Bye-bye.
Thank you.